Welcome back, everybody.
Thank you.
I guess we don't need to reconvene anything, we just start, right? Okay. Well, I want to thank everybody and let you know how much I appreciate your engagement in this subject matter. Very important to all of us. I think we've had a very engaging afternoon of discussion, and we need to make some conclusions, okay? So with that said, I am going to present a motion before the board for consideration. And obviously before that can be discussed, somebody needs to second it, okay? So this is my motion. I move that the dental board accept the recommendations that have been presented to the board by the Pediatric Anesthesia Subcommittee with the following modification. In recommendation C for pediatric general anesthesia permit for children under age 13, sub-item number 2, personnel, that the modification be that for children under the age of 7, that a dedicated general anesthesia permit holder, in addition to the treatment providing dentist, be present during the administration of, the monitoring of the patient during and through recovery, in addition to the other identified staff personnel. So basically, the modification would be that for 7 and under, that a permit holder for deep sedation and general anesthesia be a designated required monitor to monitor the patient through recovery, in addition to the dentist who is providing the treatment. This is for 7 and under.
Can I ask
now,
a question?
Unless
Just so we can discuss it, I'm going to second the motion.
Okay, good. So now we have a second to the motion. Now we can discuss. Go for it.
Okay, so the question is if you add in, oh, I thought I was using it, sorry. If you add in the dedicated general anesthesiologist, do you still have 2 additional members in addition to the dentist? Because this proposal had 2, one to monitor patient monitoring and a second person.
Right.
So would you have those 2 plus the anesthesiologist plus the dentist, or does the anesthesiologist take the place of one
Well,
of
again,
these?
I have some confusion when I'm referring to support staff when I'm dealing with anesthesia, when one of those support staff could be the assistant for the dentist who is providing the treatment. And I'm saying that we need a support staff dedicated to the anesthesia in addition to a permit holder, so that we have 2 people there, a staff and the permit holder. And then if the dentist wants to work with an assistant at the chair side, that's up to them. That's not, to me, that's not supporting the anesthesia. That's supporting the dentistry being done. And I'm concerned about the anesthesia being provided and the monitoring that's taking place for that patient's safety.
Yeah, I'm just trying to clarify if your motion is in addition to all the staff that's already in C2.
Right, I see where it starts out by saying the dentist and at least 2 support staff must be present. Again, I would feel more comfortable identifying that support staff as anesthesia support staff.
So it would be in
Maybe
place
one
of.
of the 2.
Right.
Okay, that's what I was trying, I didn't ask it very well, but it
Right.
would be one of those 2.
Yes,
Okay, got it.
good. Yes, Steve?
You carefully said dedicated GA permit holder.
Right.
So not clarification, not necessarily anesthesiologist, could be another surgeon.
Yeah, I'm identifying it as a person who's qualified to have a permit themselves, as being the dedicated person who is delivering the anesthesia and who is responsible for monitoring the patient. Now, rather than start identifying titles as to who that person might be, a dental anesthesiologist, a medical anesthesiologist, a nurse anesthetist, if they're qualified for a permit, then they meet that requirement. A permit for deep sedation and general anesthesia, not a permit for moderate or a permit for minimal, but a permit for the level of anesthesia that is being provided, which in this case would be general.
Thank you. Dr. Moore?
Yes.
I just would like to understand your thinking a little bit more about why under 7 and not under 13. I just had a separate anesthesiologist. This is not necessarily my favorite topic for a colonoscopy. And so I'm just thinking, well, if I needed a separate person for that, why wouldn't a 11-year-old want to have a separate one?
My reasoning for that, Steve, is that I'm focusing on the highest risk patient and the highest risk procedure that, in my opinion, needs the maximum protection. And let's say it's a starting point. I mean, this is a big issue that we're dealing with here. And it is not just California that's dealing with this. This is being dealt with in dental boards all around the country. And you have to start somewhere. And sometimes, in my experience, if you start and try to take too large of a bite, you end up choking on it, and it not working. So I think we have to do what we can do at this point, that we have support for, and we have some reasonable evidence. And I'm an educator, and I'm a researcher, and I'm into evidence. And yes, I know the data, the numbers that we have in our database regarding deaths under dental treatment with anesthesia are not large. They're not impressive, and that's good because we're saying, we don't have that big of a problem. But that's only one type of evidence that we need to listen to, those numbers that come out of our data collection. We need to listen to, as I mentioned earlier in my concerns, we need to listen to subject matter experts. That's evidence too. We need to look at and listen to stakeholder professional organizations that have written clinical guidelines. That's evidence too. And put all of that evidence together to make your decision. And my decisions need to be evidence supported. That does not necessarily mean hard numbers that come from controlled scientific studies. I need to listen to experts in the field. And that's where I'm saying that's the most vulnerable age. That's the heaviest level of depth of anesthesia. And that's where I would like to see us start. Yeah. Any other questions? Comment, Fran. Sorry, my peripheral vision is not what it used to be.
And again, this is just clarification. You're not suggesting a pediatric general anesthesia holder, just a general anesthesia
Permit
holder.
holder. Somebody
Permit
that
holder.
qualifies for our permit, the dental board's permit, educationally and experientially, to qualify for our general anesthesia permit.
Right.
Would satisfy that requirement, a permit holder. That's all I'm identifying it as. I don't want to get any more granular than that.
So it would not, in this case, it would not be an MD or?
It could be. I mean, we do have MD permit holders that have dental board permits for general anesthesia. We have medical permit holders.
Okay.
So it could be, as long as they hold a permit.
And it could be a nurse.
A nurse anesthetist, I don't know if our statute at this point in time or our regulations identify that a certified nurse anesthesiologist qualifies for a permit or not, I don't know. But Well, we're in the process of changing statute and regulations, so that's not that difficult to make happen. Oh, yeah? Well, it's a little more difficult, but not, for your skills and talents, no problem.
Okay, for clarification, so the motion on the floor is to accept the recommendations as stated, except to make a modification to 3C, small 2I. Dr. Morrow, can you look at the text that's already there and tell us how you would modify that?
Okay, the dentist and at least one anesthesia support staff must be present. The dentist and at least, strike that. The dentist and at least 2 support staff must be present. The dentist and at least 1 staff member must be trained in pediatric advanced life support, airway management, and equivalent, so forth. For patients under the age of 7, 1 support staff trained in pediatric advanced life support and a general anesthesia, deep sedation general anesthesia permit holder must be present in addition to the dentist delivering the treatment. The permit holder will be the designated to provide the anesthesia and to monitor the patient's vital signs, airway, etc., through the anesthesia and the recovery process. Now, that doesn't address what the dentist wants to use for a chairside assistant. I'm addressing what needs to be there for the anesthesia. What the dentist wants for a chairside assistant is up to the dentist.
I hate to do this, but could you repeat that?
So,
No?
I kind
I
of
will
lost
repeat
you
it differently.
halfway.
You got lost halfway?
Yeah.
Okay, so tell me the first part, the half you didn't get lost. See, you can't tell.
You were keeping all of this the same, determined by the board.
Right.
But then the next sentence has to do with the patient who is under 7.
Right. You realize C is dealing with patients under 13 to start with. So now, here, I'm dividing in the personnel that the first part of that still pertains to 13 years of age. The second part then kicks in when the patient is under the age of 7.
Mm-hmm.
Then there's a different scenario that takes place. That is that there needs to be a anesthesia support staff trained in advanced pediatric life support, plus a permit holder for deep and general anesthesia, in addition to the dentist providing the care. That permit holder would be responsible for administering and monitoring the patient during and through recovery.
so may I suggest some language? So for for C2, for C2, everything would stay the same?
Dr. Lay, one moment.
Sorry.
I think that the board should vote on the motion first, because it may not pass. So then there's no reason to go through the, dealing with the, to modifying the language.
But Hung could make a friendly amendment if she likes, correct?
To Dr. Morrow's motion?
Yeah, we have a motion, right?
Yeah, do
Yeah.
the first and second.
Okay.
I mean, if your language could be a friendly amendment to Dr. Morrow's motion.
I think that's what you can, of course. The board can do
Okay.
what it wants, but I think that would be cleaner.
Okay,
Just vote on the motion that's on the floor. And then if it passes, then you can work on modifying the language.
Okay, sure.
If it passes, will she be able to work on modifying it right after we pass it?
Oh, absolutely.
No, I mean, it's not really a motion, I'm just, what Dr. Mora was saying, I was just trying to kind of shorten it a little bit, make it a little bit,
You're wordsmithing it. Yeah, okay.
I mean, but, so it's not really I'm not changing the motion, I'm just, just like,
You can add some clarifying language and
yeah,
then you
just
can accept that.
basically just clarification.
Friendly amendment.
Before we do that, I think we're still, is there still room for discussion on it before we vote?
Oh, absolutely.
Okay.
Absolutely,
But
absolutely.
I'm looking at this, and we were just talking about this being at the 3,000 feet level, and we're not crossing the Ts and dotting the Is, and this is, although this is important, my question is, where does this particular document go from here? Where do we
Good
take-
question, okay.
Where do we take this, and where do, we've gotten a lot of feedback from
Okay.
the public, and there was a lot of good feedback. I just don't want to say that we've come in and there are some this is a great recommendation, but we've also gotten some good feedback too. How do we integrate that feedback into the things we just learned, and where do we go from here with this document?
Can I go with that? Okay, my understanding of that is that we have a requirement by the January the 1st that we need to submit a report to the legislature. That report it contains a number of things. One of those is a report on the deaths under dental care of children. Again, it's pediatric, during the course of having dentistry done. And the other was that we need to submit recommendations for possible change. So where I'm seeing this go to the legislature is two separate reports. One of them will be the report itself, which is our next agenda item, which we have discussed before. The second document presented to the legislature would be the recommendations that are coming out of that report. Okay? That are based on that report and the discussions that we've had here. And by the way, I want to commend all of us for taking an issue that is extremely difficult, emotional, that we all have, what should I say, we have interests in that might be different, but we have done it in a very friendly, collegial, accepting environment. And I think that's fantastic, okay? We've all behaved ourselves, which is great, and we're going to continue to do that, and we're going to work through this. We're going to work through this. This is just the beginning.
Okay.
We have the legislative process then to go through, and then the regulatory process to go through. This is the first page of this multi-paged document that we're working on right now. So I see it as submitting to the legislature to meet our requirements for Senator Hill's request, as well as AB 2235, that this is our report of the investigation, and these are our recommendations. Now, what the legislature does with those recommendations, you obviously know, and I know. That's up to the legislature as to where they go with those. Does that help you?
That helps me a lot.
Thanks.
Fran has, Fran.
Too, huh?
Okay,
Yes, ma'am.
second time. I heard you say twice that you were looking for someone trained in general anesthesia. So now, the third time, you said you wanted someone with training in pediatric life support.
No, that was the support staff.
Different person.
Okay,
The one required support staff for under 7, in addition to the general anesthesia permit holder, to be the support team for the anesthesia delivery and monitoring. in addition to the dentist who is providing the treatment, even if that dentist is a permit holder, him or herself. That's immaterial. Because with a permit holder administering the anesthesia, I, as the dentist providing the treatment, do not need a permit for anything other than a license to practice dentistry. It is that permit holder that's delivering the anesthesia and monitoring the patient that is required a permit, not me, as the dentist who's delivering. It's okay if I have one, but that doesn't take the place of the permit holder who is the dedicated anesthesia deliverer and monitor. Does that help you?
Okay. That helps, but it begs another question. For someone who holds a oral maxillofacial, or someone who is a oral surgeon, does that person also hold a general anesthesia permit?
That's up to them. Obviously, that's optional. Every oral surgeon does not have to have a general anesthesia permit. It's not required by law. However, let's take an example. If you had an oral surgery practice that had multiple oral surgeons in a group practice, and they had a child that came in that was 5 years of age, and the child needed to have an oral surgery procedure done, one of the oral surgeons in that practice could and would be the provider of the oral surgery treatment. Another one of the oral surgeons in that practice, who is a permit holder, would satisfy to be the anesthesia deliverer, monitor, and taking care of the anesthesia. Both of them could have permits. Both of them could be part of the same practice.
And so could you please repeat your modified language for me?
Let Steve do it.
Well,
Because otherwise, I would probably, I could, like,
Well, our
because only
secretary is supposed to be doing that.
C2, where it says personnel, if you all agree that what's there is good, then we could add, after the word task, we could add, in cases involving pediatric patients under 7 years of age, a second general anesthesia permit holder is required, who will provide general anesthesia and monitor airway management. Will that take care of what you're proposing?
No.
I don't think so, not to my
Because
satisfaction.
it wouldn't give you it wouldn't give the life support person.
Well, basically, the general anesthesia permit holder is required to have the, advanced cardiac life support and also everything else that goes along with the permit holder. So really, what you're proposing is to have a second person, and that person has to be a general anesthesia permit holder, who could be an oral surgeon, who could be a dental anesthesiologist or a medical anesthesiologist. I'm just trying to clean up the language and shorten it so that it's
But
not all
I'm
over
also
the place.
stating that in addition, there needs to be a support staff person who is trained in advanced pediatric life support or,
And I believe
now-
that's already here.
the reason for that is, we know things can happen very quickly, even to those of us that are providers. And a support staff person who is trained in advanced life support, pediatric advanced life support, in case, for some reason, God forbid, that the anesthesia deliverer has a problem, an issue, somebody needs to be able to take over that patient and see them through to safety.
And I believe the
So it's like
paragraph
wearing,
in
it's
this
like wearing
assistant form
a
already
belt and
includes that.
suspenders at the same time, okay? I mean, I'm looking at, why does the support person need to have training in PALS? Because it might be needed, in case,
So
for
can-
just this age category.
So
No,
can
but
I
if
suggest?
you read that paragraph, though, it's already in there. The dentist and at least 2 support staff must be present. The dentist and at least 1 staff member must be trained in pediatric advanced life support and airway management, equivalent to the AAP-APD guidelines or as determined by the board. 1 staff member trained in patient monitoring shall be dedicated to that task. In cases involving pediatric patients under 7 years of age, in addition to, thank you, a second general anesthesia permit holder is required.
That's not
Who-
it.
I mean, that's what you're proposing, right? Am I?
No,
But
I
I want,
think,
but
am
I want to make
interpreting
sure
correctly or
that,
no?
I want to make, let me address her first. I want to make sure that that person who is trained in pediatric advanced life support is not the chair assistant helping the dentist provide the treatment, but it is actually, in fact, part of the anesthesia team and not part of the dentistry delivery team.
So you're talking about at least 2 members then?
No. Here it says, dentist and I'm sorry, it says that the dentist and at least 2 support staff must be present. It doesn't say what those support staff need to be doing. They just need to be present.
Yet that paragraph.
I'm saying that an adequately trained support staff in pediatric life support needs to be dedicated to that process, not divided between chairside assisting and also anesthesia monitoring.
I think, can I try? I think
Yeah.
there needs to be a second paragraph, and it needs to say,
And that's fine.
for children under 7, the dentist will have at least 1 support staff and a dedicated general anesthesiologist.
No,
Well, that's what I thought you said.
no, no, no. You're
No,
you're
it's a
identifying
GA
a
permit
title,
holder.
and I'm saying they need to be a
I'm
permit
sorry,
holder.
don't, I won't, I took that right out of what you said, but okay. So I think there needs to be a second paragraph that says for under 7 years old, this is what's required. Because it's different than what you have for the 8 to 13-year-olds. The 8 to 13-year-olds have a dentist and 2 support staff. The under 7 and under, have a dentist, a support staff, and whatever you want to call that anesthesiologist.
A permit holder,
The permit general
general anesthesia permit holder.
anesthesiologist. So I think it needs its own paragraph so that you get the staffs correct on both ages. Friendly
I'm not
amendment?
sure, I'm not opposed to that. I think it's, the message is there anyway.
Yeah, that's my
Okay, I
friendly
mean,
amendment. It's
We
just,
can wordsmith it forever, but the message is what's important, okay? And I want it clarified that the support staff needs to be dedicated to, appropriate support staff needs to be dedicated to the anesthesia process and not divided between the dentistry delivery and the anesthesia process.
okay.
That's why I'm wording it the way I am.
So from 8 to 13.
It's
Sorry.
to support,
Well,
is it
the group
under
that's,
7.
oh, it's under 7, it's not 7 and under, it's under 7.
under
Okay,
7?
so from 7 to 13, there's a dentist, and this
And,
paragraph.
and 2 support staff, one of which must be trained in pediatric advanced life support.
And then for 6 and under.
Right, then we kick in the difference.
No, I got that, I got
Under 7.
corrected. It's 6 and under, right?
Or-
Just say under 7.
Under 7.
Because that's what the language
Well,
says.
okay. Sometimes it
Okay.
gets confusing, but, okay.
Okay, yes.
To have any training other than to be a dentist is what you mentioned earlier,
In that category of under 7,
correct?
okay?
But if a practitioner, be it a general dentist or any other practitioner for that matter, is treating a child between 7, 8, and 13, the way the language is written right now, even if they had a separate anesthesia provider, you are saying that that dentist now needs to have PALS training. It seems to me that the motion that you are making should also somehow offer the intent that that scenario supersedes some of these other requirements when the operator anesthetist model is being performed.
Okay. I think that is addressed, Dr. Complanis, in item number 3 under C, where it addresses when a dedicated anesthesia provider is utilized. In addition to the dentist, both the dentist and at least one staff member must be trained in pediatric advanced life support and airway management, equivalent to AAP, AAPD guidelines. So that's where that takes precedent, because you are adding that there is a dedicated anesthesia provider. And we're assuming that that dedicated anesthesia provider must be a permit holder, or else they'd be out of compliance. So, yes.
Gail Matthew, CDA, clarification. So I think you are saying that that GA permit holder must be a pediatric GA permit holder?
Yes.
Because, okay, so that hasn't been
And
said, so
right.
it sounded like it might be
You
any
might say an
GA permitted person.
age-appropriate permit holder.
Okay. And my other clarification is, so you have a person dedicated to the anesthesiology and the monitoring, and then a staff person who's dedicated to that monitoring team. What is that person who's not part of the treatment doing? Standing there? What is that person's job if you've got the dedicated anesthesiologist? What are you envisioning that person is doing besides standing there?
Providing support, providing another set of eyes to observe the patient. They're trained to give somewhat monitoring relief for a short period of time if necessary for the permit holder himself. That's a clinical judgment thing that takes place. I'm saying that they're there if they're needed. If something happens and you don't have somebody there in the room, sometimes it takes a while to get somebody there.
That's where I think the PALS recommendation, so I hear what you're saying, the dentist who's the treating dentist, having the PALS ability to step in and be that assisting rescue person, I think is where that is.
Yes.
So in this situation, you're saying they're hanging out as a second person?
They're supporting, okay? Now, I think what they did in the process would be determined by the case that's happening. What's going on with this case? And what does the permit holder, the dedicated anesthesia provider, what does he or she need them to do? What does he or she want them to do?
Thank you.
Yes, Steve?
I still have a question. I think that it probably would suffice to have all dental practitioners who treat children under the age of 13 have a PALS permit. I agree with the fact that if they are providing the sedation to under 13 and over 7, to have a second PALS permit assistant there. But I believe that it's probably sufficient to, because you have all practitioners treating children under the age of 13 required to have a PALS permit, then when an actual dedicated anesthesia provider comes in, then that dentist is their PALS assistant in the event of an emergency, because you generally don't need that second PALS person until you have an emergency, and in that case, the dentist would have to stop doing what they're doing anyway. They wouldn't really be necessary to have a PALS permit person hanging around, because the anesthesiologist is perfectly capable of doing the monitoring and administering the medication. The problem comes in, and this is where I do completely agree that all dentists who treat children should be required to have PALS permits, because then you have a second set of hands when you do need them.
Thank you.
No, that's where I was going. That's
Okay.
where I was going. Because the other downstream.
Mike?
The other downstream implication is you have 4 people hovering around a kid, and then you need more room, which
Right.
change all those regs.
Right. Yeah, it does get crowded.
Yeah.
It can.
I
Okay.
have one more question. The person that wrote the great idea, I just think the ages might not have been right. I know Meredith went, was it 7 to, it's the 13 to 7, and then it's under 7. Is that the way you worded it?
Yes, I did.
Okay, thank you.
Okay, any other comments or questions?
I just emailed it. We have it. Do you want me to reread it?
We still have more comments.
Yes, Sarah, do you have it?
I have the whole.
Yeah, Nick, can we just refresh our memory as to what the motion is that we are, the most recent version of the motion?
For patients ages 8 to 13, the dentist and at least
No.
two.
7 to
That's
7 to
I know.
7 to 13.
This is the full person. Do you want me to read the whole personnel thing or just the 7 and under?
No, but it should be 7 to 13 is what we keep saying. Like, we're missing a year
You don't want
there.
8?
Yeah,
Not
Want
7 and under,
7.
okay.
right, because it's under 7 is what we used elsewhere. So otherwise, now we've got different things. It's just people have kind of been mixing up the language.
Can I say 2? Usually in
Wait a
my
minute.
experience is you
Wait,
say
wait, wait.
7 to 13
Now I'm
and
confused.
6 and under.
Yeah.
Okay.
All right, read it, Sarah.
They
But
promised me no math.
what did we agree on? And I think that's what she was reading.
I
And
know,
now
but
you're
there
saying
was.
no about it.
Because there was there was a missing year, because it said, everyone keeps saying 8 to 13 and then under 7. So you're missing the
The 7.
kids who are 7 years old in one day, or 7 years old in 364 days. Because elsewhere, we talk about under 7. So really, if you put an age, then it's 7 to 13, or actually, it's up to 13, right? Which is why I'm not even sure you need to put that in there, and then it's under 7.
Okay, Sarah.
For patients ages 7 to 13, the dentist and at least 2 support staff must be present. The dentist and at least 1 staff member must be trained in pediatric advanced life support and airway management equivalent to the AAPD guidelines or as determined by the board. 1 staff member trained in patient monitoring shall be dedicated to that task. For children under 7, there shall be at least 3 people present during the procedure. 1 person shall be the practicing dentist. 1 person shall be a general anesthesia permit holder who shall be solely dedicated to administering anesthesia, monitoring the patient, and managing the airway. 1 person shall be an anesthesia support staff dedicated to the anesthesia process and shall be trained in PALS and airway management equivalent to the AAPD guidelines or as determined by the board.
Yes, and also, I was wanting it to be identified that the permit holder needs to be responsible through recovery. Was that stated?
Managing the air, okay, so who shall be solely dedicated to administering anesthesia, monitoring the patient, and managing the airway through to recovery.
Right, not through recovery, not to recovery. There's a difference.
Through to.
Through recovery.
Through recovery.
Or throughout recovery, or however you want to. Okay, I accept that language as an amendment to my original motion.
I'm very accepting.
And I'm very accepting. I'm accepting of your, okay.
So could I ask a question?
We have some discussion.
So,
We have some more discussion.
now, this only applies in outpatient settings, not
Outpatient
hospital,
settings.
not OR.
Correct.
Thank you.
Right, yes, because hospital regulations kick in there, so, yeah, it's a whole different
I
arena.
just want to make sure, because, we haven't, it's just not here, so I just wanted to make it clear.
Mm-hmm.
Thank you.
Yes,
Okay, so there's still, that was a motion within a motion? Because the motion on
No, the motion
floor
was to adopt the staff report with amended language. So the entire report's before us with the suggested amendment language.
right, okay. Yes, which one of you was first?
I'm Ariane Trelay, and I'm really speaking, I'm very confused with respect to parliamentary procedure that's happening here. And so my issue really, and I'm going to state it as past legislative chair of this board that you're sitting on, is that you're making amendments on amendments, and there's multiple things that are here. So you're not taking things individually and voting on them. And so my understanding, basically, if you're following parliamentary procedure, you're going to vote on whether you accept the amendment. If you don't accept the amendment, then you can still accept the resolution. But there's a lot going on here, and I respect all the work that's being done, and I appreciate the fact you're even letting me speak. But there's a lot of input here, and there doesn't seem to be order, nor parliamentary procedure is for fairness, and it's getting very confusing.
Okay, thank you, I appreciate that.
With all due respect, a person who makes a motion can always amend it before it's been voted on, so long as the second accepted the amendment. Okay? So I understand. I understand how you can be confused because it's been amended twice now. They can do that. They can do that. So now there's another amended motion on the floor. Thank you.
Okay. Yes.
I realize a lot of the details will be hashed out at a later point, but the PALS issue keeps coming up over and over again in various categories, and I'm just wondering if that's the most appropriate training vehicle for support staff, especially in light of the fact that PALS training trains to treat cardiovascular conditions which require the administration of drugs, which assistants are not able to do.
Well taken, but, or equivalent, or?
Yeah, the idea was, PALS is a course. It doesn't necessarily provide authorization to administer medications. It's PALS or equivalent as other courses that might be more appropriate are developed and implemented. The board would have the option of recognizing those.
Thank you.
President, I call a question.
Okay, question has been called. Now, do we want to read it once more? Just to make sure, okay? Let's make sure we're on the same page.
All the
Sarah.
ages right.
Okay.
So the motion in its entirety is to accept the recommendations presented by the subcommittee with the following modifications to recommendation 3CII. Personnel, for patients ages 7 to 13, the dentist and at least 2 support staff must be present. The dentist and at least 1 staff member must be trained in pediatric advanced life support and airway management, equivalent to the AAP-AAPD guidelines or as determined by the board. 1 staff member trained in patient monitoring shall be dedicated to that task. For children under 7, there shall be at least 3 people present during the procedure. 1 person shall be the practicing dentist. 1 person shall be the general anesthesia permit holder, who shall be solely dedicated to administering anesthesia, monitoring the patient, and managing the airway through recovery. 1 person shall be an anesthesia support staff dedicated to the anesthesia process and shall be trained in PALS and airway management equivalent to the AAP-AAPD guidelines or as determined by the board.
Okay. Okay. The question has been called. Please do the roll call.
Stephen Morrow,
Yes.
Judith Forsythe,
Yes.
Steve Affria, aye. Fran Burton,
Aye.
Stephen Chan,
No.
Yvette Chappelle Ingram,
Aye.
Katie Dawson,
Aye.
Kathleen King,
Aye.
Ross Lai,
Yes.
Juan Lay,
Yes.
Meredith McKenzie,
No.
Thomas Stewart,
Yes.
Bruce Witcher,
No.
Deborah Wu.
Yes.
Mr. President, it's 11 ayes and 3 noes. The motion carries.
Thank you. We are now. Okay. We'll move on now to agenda item 10B.
Okay.
And that again will be handled by the Pediatric Anesthesia Subcommittee.
Okay, so 10B, so as you can see here, this is the report that we did on the California Pediatric Sedation Study. So you have all seen this actually several times already. I think it's substantially the same that you've seen in July, I think again in, at least 2 more times. We have received some comments which have been incorporated, but it's substantially similar. So I think at this point, we're just looking for any substantive comments, if there were any that have not already been provided these past 3 times that you've seen it.
Okay. With that said, do any of the board members have any substantive comments to make regarding the report that has been submitted to us by the Anesthesia Subcommittee? Yes.
I have some comments about some things that I think are extraneous in here that can come out. I would suggest that it doesn't have to be done today. What I'd like to move is that we accept this in concept and for people who have edits, that they get them back to?
I can't accept it by concept.
Okay.
Yeah, I
And
guess,
so we then have to go through this page by page.
If you have substantive.
if it's substantive,
if
right?
it-
If it's
if
non-substantive,
If it's non-substantive, then it's not necessary to bring up to discuss today. So we're looking for substantive changes. Yes, Bruce?
Could I make a comment? With all due respect, this report has been before the board at two prior meetings.
Yeah.
It's been out for
Three-
comment since
three,
July
right?
24th.
Two.
I think it would be perfectly acceptable to accept editorial changes, but I think to go beyond that, I think it's too late.
I agree.
okay.
I
I
don't-
can move to accept the report then.
It's been moved and seconded?
Public comment on this agenda item?
Well, we haven't commented yet.
Yeah, we
Okay.
will still discuss, but.
Yes. It's been moved and seconded, so any comments from the board members regarding this motion?
And I don't know if this is appropriate with this document, but my impression is anesthesia is being used in young children more and more every year. And I don't know if there's some way to track that, because I couldn't figure that out. And you almost can't track what you have in here. So is there a way to, in the future, somehow figure out, is anesthesia use going up in the under 7-year-olds? Yeah, I'm asking Bruce.
I don't think there's any question, but that use is up across the board.
And there's no real way to track it? because
It's
we-
being done in so many different places and so many different settings by
Yeah.
so many different people. You know, the literature addresses that question, including some of the references that have been provided in the
Right.
report.
If there were some way to just give a comment to Senator Hill, that this has been very hard to track, and somehow what needs to come out of this is a better way of tracking.
I believe that's addressed by the report.
That's what I thought, okay.
I think so too.
Okay, this is where we are at this point. If you need to make changes to the report, I would suggest we table it for tomorrow. This report, if not accepted today, we will have to have another meeting scheduled before the end of the year, which would probably have to be in 10 days, well, it'd have to be in 15 days to allow us to give a 10-day notice.
In Los Angeles, I might add.
Well,
Just trying to support
or,
your efforts here.
or if you move forward with what is before you, I would recommend we strike that it's 4 parts, take off the conclusions, and accept the report as written. Essentially what it is, it's the study that we were requested to do, comparing our state statute and regulations with other states' guidelines. The recommendations that you have put forward would be a separate item that may or may not accompany the report, but it would be addressed to Senator Hill as essentially board recommendations, but not as formally part of the report. Our legal counsel has said that if you want the recommendations actually to be part of the report, we do have to have another meeting. Because what the report is going to look like, minus obviously the table of contents and the cover page, needs to be, you all need to have seen it. And if you accept what's before you with what I just recommended, that essentially we make it a 3-part study, we take off the reference to conclusions, you'll see that the last page has part 4 conclusions, we delete that, and this study gets submitted in time to meet the January 1st deadline.
I move to accept. I'm not kidding.
No, we already have that.
I mean, can we just go with that? Yeah.
Well,
We've
no,
seen it,
if
so-
you
Not if
incorporate,
we add.
if
If we
you,
make any changes.
right.
So the motion that's before us, we could adopt and comply with the Senator Hill's bill.
Yes.
With my suggestion
Right.
that you remove the reference to conclusions, since there won't be any.
Yeah, I would amend my motion to remove the reference to conclusions and otherwise accept.
know.
Okay, so it's been moved and seconded to accept the report as presented, with the exception of removing reference to conclusions in paragraph 3 on page number 1.
And can I just ask, so then everything that was covered in 10A would be given to Senator Hill separately?
Yes.
That's right.
Okay, that's,
Right, there would be 2 separate items issued to Senator Hill and to the legislature. One would be the report, a standalone report. The other would be a standalone recommendations.
got it. And Fran has her.
Yes.
Okay, so there are some things in here, for instance, at the bottom of page 1, where you talk about the people who first utilized the techniques. I don't think that that's necessary. I think that you could start a sentence by saying new techniques and new anesthetics became available, and not add that. Then in midway, there is a reference to the board's last sunset review. I don't know what that has to do with this. My next question is on page 7, where we talk about the fact that there have been a couple of discussions about providing some update, but that the proposal was identified as a future board priority, and that's just sort of left hanging. I think that it could be stated differently so that it doesn't appear, the way this reads to me is that the board abandoned it, and that was not the case. And so there are some things like that that I am concerned about that are in here that are basic kind of cleanup things that I'd like to have considered as a part of this motion.
Is that a motion you're making as an amendment to the motion?
Friendly amendment, I
Making a
guess.
friendly amendment.
Yes.
Okay. A friendly amendment has been made to the motion?
No, I don't think I accept that, because that would be amending the document. I mean,
That's correct.
once again, if there's like typos, administrative type errors, I think that can be dealt with no matter what, but that, I think, would be more significant amendment. So I don't accept that to my motion anyway.
However, if the motion fails, Fran, then you can make a motion to remove those certain things, or whatever you choose to do. But the motion is on the floor, and you want to call the question?
Yes. Okay.
Public comment?
Public comment on the motion? Are you awake out there? Okay. Yeah, okay. Somebody is, they stood up, so, fantastic.
Hi, my name is Sebastian Kaplan again. I think that we're having this discussion, and Senator Hill sent his letter because my nephew died. In 1999, 60 Minutes did a story on dental anesthesia because too many children had died. There was a Blue Ribbon Commission, as I understand, that happened after that with this board that suggested a permanent standing committee on pediatric anesthesia, or perhaps just dental anesthesia generally. And to my knowledge, that doesn't currently exist and hasn't existed for some time. So my request, and thank you for all the consideration that you've given to these proposals and the work that you've done so far, and this isn't going to stop, and we're not going to stop until kids are safe and people are safe. And it just seems like this should be the highest priority of the board, because this is where people die. And if safety is paramount, and it is, that's the statutory mission, then this should be something that the board is considering, maybe not continuously, but continually, as a regular part of the board's discussions and deliberations, so that we're not adding requirements like capnography after the fact, and that the board can be proactive in doing that. I don't know if that needs to amend the report, or maybe a cover letter to Senator Hill, or just a commitment that this board takes on. But I would ask that this is something that the board seriously consider as an allocation of its resources to have a permanent standing committee to consider sedation in dentistry. Thank you.
Thank you for your comments and contribution. Okay, so we have called, any other comments regarding the motion? from the public in attendance? Okay, you do the roll call. Secretary Afriat. I'm getting so formal here. aren't I?
I just want to say thank you to Bruce and Meredith. This was just a lot.
Oh,
Thank you.
amazing.
Stephen Morrow,
Yes.
Judith Forsythe,
Yes.
Steve Afriat, aye. Fran Burton,
No, is that the changes? No.
Stephen Chan,
Yes.
Yvette Chappelle Ingram,
Yes.
Katie Dawson, Kathleen King,
Yes.
Ross Lay. Lai. Got it right all day. Huang Lei,
Yes.
Meredith McKenzie,
Yes.
Thomas Stewart,
Yes.
Bruce Witcher,
Yes.
Deborah Wu.
Yes.
13 ayes and 1 no. Motion carries.
Thank you very much. Let's sort of take stock of where we are right now, okay? Take a deep breath. At this point in time, I think the Dental Assisting Council is probably either left or need to leave very soon. I understand they had a plane to catch or something. So that probably will be tabled until our next meeting, because they will not be here tomorrow. Is that right?
I think their times are changing.
Were the dental assistants?
Yeah, they're here.
Are they here?
Yeah, they're here.
Do we have time, Judy, do we have time to do the joint, or at least a portion of it?
For the joint committee?
Yeah. Did they, I was told that they needed to leave, because they had any plans to go.
Okay, so, Dental Assisting Council, are you available? For how long?
We can knock it off.
Let's do it.
It's worth it.
Let's do some of it.
Where are we?
I want to get the Perio report.
So we'll do 11.
Okay. We're going to, at this point, we're going to move on to agenda item 11. That is the periodontist request report. And Dr. Kaplanis, I appreciate your indulgence and apologize for needing you to stay here so long, and I appreciate that.
No problem at all. I enjoyed the day, and I thank you for giving us this opportunity again to present this idea to all of you again. On behalf of the California Society of Periodontists, as well as in cooperation with the California Society of Dental Hygiene, or dental hygienists, we are requesting that the Dental Board recognize the month of March as Gum Disease Awareness Month. As many of you may know, periodontal disease leads to bone loss and tooth loss and can significantly compromise overall systemic health. Periodontal disease affects more adults than cancer, diabetes, or even heart disease, and approximately 70 to 85% of the general population is affected with some form of periodontal disease, but less than half are aware of being affected. It is a major health issue. Periodontal disease have been associated with increased risk of heart disease, stroke, preterm birth, low birth weight newborns. Recent research has also made connections with other serious medical conditions, including diabetes, early onset dementia, chronic kidney disease, especially in the African American subpopulation, pancreatic cancer, rheumatoid arthritis, Parkinson's disease, and for the men in the board and in the audience, even erectile dysfunction. The link has become so apparent that some medical plans are beginning to acknowledge the benefits of treating periodontal disease by providing coverage, albeit limited, to help reduce overall medical expenditures. And recent papers published in Health Economics, as well as the Journal of California Dental Association, has shown that treatment of periodontal disease can reduce overall healthcare costs and utilization. Approximately 42 states have already made a proclamation making 1 month Gum Disease Awareness Month. We are in the minority here. I'd like to address some of the concerns that this board had and some of the audience had the last time we presented this issue back in March. The first one was whether or not the dental board was the appropriate entity to present this. According to the dental board's mission statement and your vision statement, oral health promotion is one of your goals. And what better than to increase public health awareness to the most common oral disease that affects adults today. Periodontal disease is the biggest disease problem that we see in adult dentistry. There was a concern about the commercialism association. It is true that there are 2, possibly 3 entities, Colgate, Millennium Dental, and there might be a third in there, Palmolive or something, that recognize the month of February as Gum Disease Awareness Month. We are asking that we recognize March as Gum Disease Awareness Month, which will satisfy any concerns that this is being asked for or promoted, or even any suggestion of conflict of interest by asking for the month of March to be our month in the state of California. And then lastly, there was a concern that this would open the doors for some other dental specialties to request for their own special interest. And to that, I'd say that this is not a special interest issue. It is true that I'm a periodontist and I treat periodontal disease, but the reality is that periodontal disease affects everyone in dentistry. The majority of periodontal disease is treated by general dentists. When disease gets advanced, it is true that the periodontist gets involved. But when it gets very advanced, we also have the involvement of endodontists. And when it gets really involved, we can have facial infections that then our oral maxillofacial colleagues get involved with at that point. The orthodontist, when treating adult patients, need to recognize periodontal disease and will often send their patients for a periodontal clearance, as litigation against orthodontists has become a common problem because of the failure to diagnose periodontal disease before treating orthodontic therapy. So this affects everybody in the family of dentistry, not just periodontists, but general dentists and endodontists and orthodontists and oral surgeons, as well as hygienists who are given the task of maintaining control of the disease once disease is put under control. So we are respectfully asking that this board recognize the month of March as Gum Disease Awareness Month, and we ask for nothing else other than that awareness.
Okay, thank you. Does any board member have any comments or questions for Dr. Kaplanis regarding his request? Yes.
I'd just like to say I very much support that request and think it's the right thing to do for the folks of California.
Yes.
There was a discussion about this item at the CDA House, and I believe they voted to refer it to the ADA, which I think may have a similar program. Maybe you could elaborate on that.
Yeah, let me elaborate on that. So we brought this forward to the CDA House in order to obtain some of the resources or have CDA help us with the resource of spreading the message out. There was a substitute resolution made to refer back to the ADA as they are already involved with a similar campaign in conjunction with Colgate. However, that substitute resolution was defeated, and then the original resolution for the recognition went forward, and in the end, the vote had requested that the resolution go back to CDA in order to flesh out all of the details of what this would entail from a work standpoint on the behalf of the CDA staff, as well as the resources that would be required to accommodate the requests that we were making. So I believe that we'll see the resolution back at, well, I guarantee that it will be back because I will reintroduce it again next year. But I think at that point it should come back from the CDA, and hopefully we will have come to an agreement of what their role will be in this campaign of awareness.
Okay, thank you. Yes, Brian?
Just a quick question. Is it your plan to ask the governor for a resolution, or go through the legislature for a resolution as well?
Yes, it is our plan that we will also go to the governor and hopefully achieve a proclamation as well.
Okay.
Any other comments, comments or questions? You know, maybe I'm the only one, and if that's the case, I'm the only one. But I don't know for sure what the board can do. I mean, what are our powers? What are our limitations? I don't think the board can make a proclamation. We could support the concept if that request is to the legislature or to the governor. But I don't think that we have any power or authority other than to support it. So I think at this point in time, I would like to see this board go on record anyway of supporting the effort to establish a gum awareness month.
Gum Disease Awareness Month.
Gum Disease Awareness Month, right. Gum Awareness Month. Gum Disease Awareness Month.
We don't need to be aware of our gums.
We're there, okay. But other than that, I don't know for sure what we can do at this point, other than to go on record of supporting it.
That's what he
May I have
wants.
the privilege of making that motion?
Yes, Dr. Stewart?
Second. Well, I thought you made.
Me, I didn't say it.
I said it because I thought you made the motion. Oh, sorry.
So it has been seconded?
No, it's Tom's motion.
I
don't think I
it's
made
confusing because you were going to make that motion?
Yes.
So you can just go ahead and accept what he stated.
That's what I
I
thought
don't
I
think,
did.
wait, let me
He said
back
so
up.
moved, right?
If I misspoke, which I do
Second.
often, I was not making that as a motion. I was simply making that as a statement to the board that I thought that we should do that.
I tried to turn that statement into a motion, I'm sorry. I probably was.
So, and you did. So it's Dr. Stewart's motion.
I have your name right here. Is the-
Good, good.
And I seconded it, just a little too quickly. Sorry, Tom.
Okay, so it's been moved and seconded. Any more comments or questions from the board?
I will
Public.
just add
Nope,
that I
sorry.
know how hard it is to do this because I did something like that in my county, and I appreciate the effort you're putting into this.
Thank you.
Thank you.
And Mr. Chairman, this is a very serious issue. I would appreciate a little more seriousness in the vote.
Can I get more serious? I'm being asked. Yes, I
Show
can.
your own gums.
No, I won't take that personally, too much. Okay, any other comments from the public? I see we have a patient lady.
Lisa Okamoto, California Dental Hygienists Association. We are fully planning to collaborate with CSP on this, asking the governor for a proclamation recognizing this. I think as we move forward, we really want the public to be aware that oral health is part of overall health, and it's been considered separate for a long, long time. Gum disease is unrecognized, I would say, underrecognized, if at all, by the majority of the population. So any support that you can lend this is much appreciated. Thank you.
Thank you. Any other comments, questions? Call the question, call the roll, please.
Stephen Morrow.
Yes.
Judith Forsythe.
Yes.
Steve Afrigat, aye. Fran Burton.
Yes.
Stephen Chan.
Yes.
Yvette Chappelle Ingram.
Aye.
Katie Dawson.
Yes.
Kathleen King.
Yes.
Ross Lay. Lai. I only get the first 10 right. Dr. Ross Lai. Huang Lei.
Yes.
Meredith McKenzie.
Yes.
Thomas Stewart.
Yes.
Bruce Witcher.
Yes.
Deborah Wu, you have this to look forward to.
But I won't mispronounce his name. Because, yes.
Yes, you did. Mr. President, that's 14 ayes.
Thank you very much.
Thank you.
Okay. Okay, we are now going to move into a joint session with the Dental Board and the Dental Assisting Council. So if we can squeeze together and make some room for the Dental Council members. Yeah. Okay, there's some empty seats, and
Dental Assisting Council, there's 3 seats at the testimony table you can take in, and then I think we'll have one, there's a space up here.
There's a seat over here.
How many more do we need?
There's one here.
No problem. It's just elsewhere. Under.
So this is for the roll call, this is for other stuff. Thank you.
Okay, everybody ready? Okay, we'll first go into joint agenda item number 2, which is approval of the minutes from the August 16 meeting. You all had these in advance. Oh, that's right. I'm sorry, I got ahead of myself. Since the board has already called a roll and established a quorum, but the Dental Assisting Council has not, we need to make a roll call and establish a quorum for the Dental Assisting Council. And I don't have a roll for that. Okay, Ann can do that.
Okay. Ann Contreras, present. Pamela Davis-Washington.
Present.
Tamara McNeely. Present. And Emma Ramos.
Present.
We have a quorum.
Thank you. Okay, now we can go to the minutes from the August meeting. Any comments or questions, suggestions regarding the minutes as presented?
Move to accept.
Move to accept. Do I have a second?
Second.
I'm sorry, who moved to accept?
I did, fourth.
And second?
Pam Washington. Okay.
Okay, I'll call the board members, dental board members. I'll call everybody. Morrow?
Oh, I'm sorry, public comment on the minutes. Any members of the public in attendance have any comments or questions regarding the minutes as presented? Thank you.
Morrow?
Yes.
Forsythe?
Here. Oh, sorry, yes.
Afriet abstains. Burton?
Yes.
Chappelle Ingram? Okay. Dawson? Is that yes or no?
Yes.
Kathleen King?
Yes.
Lai?
Yes.
Legg?
Yes.
Mackenzie?
Yes.
Stewart?
Yes.
Witcher?
Yes.
Wu?
I mean, yes.
Contreras?
Yes.
Ramos?
Yes.
Davis Washington?
Yes.
McNeely?
Yes.
That is 16 ayes, 1 abstention, and 1 absent.
Okay, thank you very much. And Ms. Judy Forsythe, who is the Vice President of the Dental Board and also a member of the Dental Assisting Council, will lead out in these agenda items.
Okay, agenda item 3, update on dental assistant program and course application statistics.
Sarah Wallace, Assistant Executive Officer and Manager of the Dental Assisting Program for the Dental Board. This memo just gives an overview of how active we've been in the review and approval of our programs and course applications through 2016. You'll see at the tables, Table 1 and Table 2, the bottom of page 1 of your memo is a summary of the applications and site visits conducted all year. On the next page, you'll see a summary of the applications that have been reviewed and approved since the last board meeting in August. And then a breakout on the following page of those specific programs and courses that have been approved since the last board meeting. I'd be happy to answer any questions if you have any.
Are there any further questions on agenda item 3? Move on to agenda item 4, update on the dental assisting examination statistics.
I have a memo here that Zach's going to hand out to the board members and the council. The examination statistics were going to be hand-carried items because we were having issues with our reporting system. And so these were just finished yesterday. The first page of the memo outlines the written exam and practical examination statistics, breakdown between north and south, and the written examinations and the overall pass rates. The second page gives an overall pass rate over the duration of 5 years. And then the statistics also include the breakdown of the individual programs, passing scores, and these passing scores will now be reported on the board's website since we've finally received updated information. So we'll get these up on the board website next week.
Give them just 2 seconds to look it over.
Question?
Sure, go, Dr.
For Sarah, sir, is it fair to ask for you to summarize, are we going in the right direction?
Good question.
Is that a fair question?
That's a loaded question.
We're getting through the meeting.
It depends on what weekend we're talking about.
Which weekend we're talking about?
So we're working on it, and I'll be sharing more in the report later about the review that we're doing of the practical exam. So the statistics are what they are at this point. So as a result of having the candidate guide, I don't think that we've seen a significant increase in the passing rate.
How many exams have we done with the candidate guide?
3.
Okay. Any other questions from the board members? Discussion?
Quick question, point of clarification. So you also have the RDA-EF results back here too, not just RDA?
Correct. All of our dental assisting examinations, including the written examinations and for the OA and the DSA as well.
Any other discussions from board members? Public comment? Move on to agenda item 5, update on dental assisting licensing statistics.
During the full board meeting, we've gained a new staff member in our dental licensing unit who's been very successful at running the statistics on the dentistry side, and so he's also working with me to update the statistics for the dental assisting side. Unfortunately, we didn't have those quite in time for this meeting to have a full breakdown for the dental assisting, but we are looking at the next meeting of having a more robust analysis of our statistical information. What is provided, you will notice that seems to be a discrepancy since the last August meeting, and now there's a variation in the numbers. We believe that these are the most significant numbers, that these are accurate at this time. I would like to point out that the delinquent number does seem high, and one of the discussions that came out of the August meeting in the dental licensure was to look at the delinquency, and what we have found on both the DDS and the RDA side is there's duplication in the statistical reporting. So I would venture to assume a good portion of those 11,000 are duplicates, and we're working to rectify how to sift those duplicates out of the report.
Any discussion from board members? Public comment? Moving on to agenda item 6. It's an update of possible combining of the registered dental assistant, law and ethics, and written examination in accordance with the Business and Professions Code, Section 139 requirements. Is Dr. Lenser still here?
She's hung out.
Yeah, still here.
So Karen and I had met with Dr. Linser and her staff over at OPES about a month or so ago to review the law and ethics and written examination again. And so it is their strong recommendation that the examinations be combined into one 100-item written examination. And Karen and I believe that we can do this easily as it relates to statute. And so we've asked Dr. Linser here to also present to it and be available to answer any questions that may come up.
Okay, so basically, as we did an update to your occupational
Heidi,
analysis.
I'm sorry, could you pull the mic real
sorry.
close to you?
Thank you. So as you know, we did, OPES conducted an occupational analysis for the RDA practice. And during the course of that report, we determined a lot of changes that were identified compared to the previous occupational analysis and the resulting examination outline. And what we looked at was basically a lot of the content that we had covered in the previous, or we're covering in the current examination, were no longer indicated as content valid in this new occupational analysis. So that's leaving us with sort of a gap in developing an examination. And if you look at the two test plans, so you have that in your packet, or you have my memo in your packet, but when you look at the two test plans for the law and ethics versus your general written examination, there's a lot of overlap in the content areas. And so what has basically been done was the practice has just been divided sort of arbitrarily into law and ethics and general practice. For a lot of the professions, these are just combined into one examination. And because they're both 50-item examinations, we believe that a stronger exam would be a 100-item exam. It also gives us the opportunity to write questions that are more scenario-based that can incorporate the ethics issue in with a practice type of question. So you're practicing and an ethical issue comes up. So it makes for a stronger examination with better questions. And also a 100-item examination is more reliable. You have more questions for the person, provides more reliability as far as assessing the competency of your candidates. And it's also in line with what you do with your other professions. For dentists, you have just one examination, and for the EFs and for the hygienist. So we think that it removes one of the barriers for licensure, in that they only would have to take one combined test instead of paying for two separate tests.
Good.
May I just make a comment in
Sure.
support of this? I felt it was a very good report, and I was in favor of another barrier being removed for them, and also statistically, it does provide a better test pool in addition, so thank you for that.
Does this require a motion?
I don't
Yes.
think so. I'm sorry.
Yeah, actually, we do.
So motion to accept?
Yes.
So-
Yes. The recommendation to combine the law and
To-
ethics and the written exam.
Yeah.
That'd be the motion.
So is it to direct staff to work with OPES in, is that what the motion is?
So the motion, yeah, so the motion is that the board and council consider and direct staff to work with the DCA Office of Professional Examination Services to update and combine the RDA written and law and ethics exams into one 100-item written examination based on the findings that were recently completed in the occupational analysis.
Was there a second?
Yes. I seconded it. She made it, I seconded it.
Thank you.
Any further discussion from the board members? Public comment?
Hello there. My name is Melody Randolph, and I'm representing the Dental Assisting Educators Group of California. We surveyed our members and had a response back of between 30 and 40 responses to this issue. All of the responses, with the exception of one, was in favor of combining them, but we have serious concern about it only being 100 questions. The current RDA written exam, unless it's changed, I've never heard of it only being 50 questions. It's 155 questions, and the law and ethics exam is 50. So none of the people that responded, none of the educators in California, dental assisting educators, were in favor of reducing the total amount of questions down to 100 questions.
Is that correct?
The test has always been 155 with 10 questions or so being your test questions. I've been teaching for over 25 years, and it's never been only 50 questions.
I was under that same impression.
Yeah, well, that's, my apologies for not knowing that. We haven't been working on the general written.
Right. I was under the impression that the written was at 100 questions, and there may have been additional added in for the testing
Pre-test.
question, pre-test questions. But if we, I don't know that we necessarily need to be committed to the 100. We could just direct staff to work with OPS to combine the exams, and then.
And I think
Could you just combine?
Dr. Linzer has reported on this. It's not the quantity, it's the quality of the questions, and I think it's best left to OPES to determine the number. I think at this point, the vote should be related to whether or not we would be combining the two examinations and leave it up to the experts to determine the number that would be used.
And I would agree with that. It's not the quantity of the questions, it's the quality of the questions.
If I can add, a number of our members stated the same thing, but I'd like us all to keep in mind as well that the national board exam to become a CDA is 300 questions. There's 3 separate tests, and all 3 of the tests are 100 questions each. So for us to go to a 100 question test would really deviate from the national board exam, which is a total of 300 questions.
And just for clarification, if I may, that national exam, 100 questions is devoted to infection control, 100 questions devoted to radiation safety, 100 questions to general chair-side assisting. So that's where the 300 total came from.
Well, what we can do is, we have ongoing workshops scheduled for the RDA, so we will convene a workshop, and we would have to anyway, in order to combine the exams, and review with the subject matter experts and get their recommendations, and can report back, discuss it with staff or the board as you see fit.
Okay. Any further discussion, board members? Go ahead, Yvette.
Yes, given this, there seems to be some confusion about the number, and there seems to be some concern about the numbers declining, and I hear national involved in there. I'm really kind of reluctant to vote on something, and we don't have all the facts. And so I think we really need to have the facts first, and so that we don't put people in positions so that they're not worse off. And
Well, our major
better off.
concern was the law and ethics exam, which is what.
Okay, that's the first I'm hearing of that now.
Okay,
We were
so the
getting
major
ready to
concern
vote.
is the law and ethics exam that OPS has been providing to your board. We haven't been providing the general written.
Oh, wait, I'm sorry.
So.
Okay, I need some help.
Okay, so some issue with the law and ethics, based on the occupational analysis, the bank of questions that we have will not support the new occupational analysis. The scope is much more narrow than it was. And so that's why the recommendation to combine the 2 exams, because we don't feel there's a wide enough scope to make a valid exam.
And this is just law and ethics?
Yes.
Mr. President, I'd like to ask, just to make people comfortable, for a friendly amendment, because what we're really voting on is just combining the two exams, and a friendly amendment that staff report back to us on any further exam details. So that right now we get staff working on merging the two exams, and we don't have to spend time today worrying about how many questions there are or those kind of details.
Because we should leave that up to Opus.
Agreed.
So that would be my friendly amendment if Deborah, you're willing to accept it. And
I'm willing to
Tom's
accept
willing
that.
to accept it. Maybe that'll help
Yeah,
resolve
we
this.
my understanding was the motion was just to combine, not the details.
Right, but I hear some concern
Yeah.
from other board members.
Okay, then we have to amend the motion because the motion as it stands, does have the 100 question in there.
Okay.
I agree. Just trying to alleviate concerns that people are expressing.
So would you like me to restate or make a motion to, the motion should be to combine the RDA, the ethics, the law and ethics with
The RDA written exam.
the current written exam?
That's correct.
Yes.
I'll second.
Well, actually,
Where are you
Dr.
at?
Stewart,
Dr. Stewart already
you
accepted.
accept that?
Yes.
Public comment?
I'd just like to also state one additional thing, though our members are fine and in agreement with merging them, the hygienists still have to take more than one written exam. They take a national and the law and ethics. The argument that EFs only have to take one exam, well, that's because they've already become an RDA, taken the two written exams. And so the logic is kind of erroneous there that other dental professionals only have to take one exam. So if we're trying to make this equivalent to other licensees, that's not necessarily being accomplished because hygienists are taking more than one, dentists take more than one.
The RDAs need to take the practical also. They have
Right.
two. So they all have two, not three. That was-
No, the hygienists have three. They have a practical, they have a national written, and they have the law and ethics. So they do have two written exams.
I understand that KDAT can submit information, material suggestions to the board during the process that would be considered in the development and the combining of the two exams. So you're free to do that in written format and send them to the board staff.
Thank you.
Okay?
Tamara?
Thank you. I just like clarification. Where do we go from here? What does it look like? I know it says that they'll meet with stakeholders and the SMEs first of the year. Is that what we're looking at, somewhere around there? And then moving forward, what is the anticipated timeline? Do we even have an idea as to what that's going to take?
No, I think you might be referring to another agenda item in
Thank
here.
you.
But what would happen next is we would meet with OPS and we would put together an interagency contract, and then that interagency contract would outline all of the tasks and timeline
Okay.
involved. And
That's
so
what I needed to
Then
know.
we would work with OPS to recruit for those workshops.
Okay, thank you.
Any further discussion for the board members? Public comment? Call the vote?
Steve Morrow,
Yes.
Judith Forsythe,
Yes.
Steve Afriat, aye. Fran Burton. Yvette Chappelle Ingram,
Yes.
Katie Dawson. Kathleen King,
Yes.
Ross Lai.
Yes.
Huang Lei,
Yes.
Meredith McKenzie,
Yes.
Thomas Stewart,
Yes.
Bruce Witcher. Yes. Deborah Wu,
Yes.
Ann Contreras.
Yes.
Emma Ramos.
Yes.
Pamela Davis Washington,
Yes.
Tamara McNeely.
Yes.
That's 18 ayes.
Agenda item 7, update on the 2017 examination schedule.
The 2017 examination schedule was just finalized within the last few weeks with our facilities. And so we've submitted out the schedule. And so the filing period has actually started and will end next week for the February examinations in Pomona and San Francisco. This will be the last year that we'll be able to utilize the Carrington College Pomona site. So we are in the process of looking for an additional Southern California site. And we are looking at adding an additional examination in July, which is also another agenda item on here.
Any discussion from board members?
I have a question. I don't know if this is the right time.
Put your
Oh,
mic
sorry.
closer, we can hear you.
I don't know if this is the right time to bring it up. Being that the first exam for 2017 is in February, the exam in November of 2016 was canceled, so are those assistants going to be transferred to the February?
No, we are working on scheduling another full weekend for those candidates.
Okay. Thank
Sooner
you.
than February.
Any other comments or discussions from board members?
Will it only be open to those candidates, those 500 candidates that
Yes.
were canceled?
Yes. We're not taking any additional applications. They will merely just be rescheduled for those dates. Ideally, they'll be rescheduled for the exact same sessions. There's no need for them to submit additional applications or fees or do anything. We will be in contact with them.
Okay.
I just wanted to note that our exam chair, Dr. Wu, is planning to attend the exams next year to observe how they're administered.
All 9 of them.
Any further discussion from board members? Public comment? Moving on to agenda item 8, discussion and possible action regarding the location of the 2017 Registered Dental Assistant Practical Exam.
So the 2017 exam schedule has been put out there. For the past several years, we've administered the RDA practical exam and in a location at Allen Hancock College in Santa Maria, California. This past year, we offered the examination at San Joaquin Valley College in Fresno. We actually had a really good turnout at the Fresno examination, and we had a lot of good feedback, but we've also received some feedback from schools and local dentists in the Santa Maria location that they're requesting that the exam be held again in Santa Maria rather than Fresno, with the understanding that the board can only accommodate administering one more RDA practical exam. We've brought this back to the board and the Dental Assisting Council to ask for direction as to which location you would like us to administer the examination in, either Santa Maria or Fresno. Just to lay out some facts, the Santa Maria site, as of right now, the bid came in at about $1,700 more for the facility cost than what the bid was for the Fresno test. And the Santa Maria test, we usually get about 150 to maybe 200 candidates to test in that location. To give you some perspective, on a usual weekend, we test up to 540 candidates. And so what we were actually able to accommodate at the Fresno exam was 540 candidates. So it seemed to relieve some of the overflow from the San Francisco and even the Pomona examinations, and we did get good feedback about it. It was an easier facility to reach in terms of travel because it was right in the corridor. And so I respectfully request that the board and the Dental Assisting Council make a determination as to whether or not we should test in Santa Maria or Fresno this coming year.
Anybody want to start the discussion? Dr. Witcher?
I believe the Santa Maria location is actually offering free accommodation to the candidates. I think they're supporting their hotel. Is that not the case?
My understanding was they may be able to offset some of the costs, but the cost of the facility wouldn't outweigh the cost of the.
Tamara?
This is something that the Central Valley has been asking for several years, and they spoke loud and clear as to the need to have an exam in the Central Valley. We received numerous calls from people who postponed applying to other ones to wait for the July because of the cost. And the numbers showed that the Central Valley is definitely a viable option for these candidates and to reduce their travel and expenses because they can travel within, just an hour to an hour and a half and not have to have those additional expenses. also.
I move that we select the Fresno site.
I second.
You guys are quick on your
We have
motions.
a motion and a second. Any further discussion?
I moved that we accept the Fresno site.
Okay.
It allows discussion if we need it.
I think that makes sense. It's simple math. We're serving more people, so I think that makes the most sense. Any other discussion?
I can go.
Dr. Stewart?
Yes.
Okay.
Fran is distracting me, I'm sorry.
Any public comment? We'll call the vote.
Stephen Morrow.
Yes.
Judith Forsythe.
Yes.
Steve Afrieta, aye. Fran Burton. Yvette Chappelle Ingram.
Yes.
Katie Dawson. Kathleen King.
Yes.
Ross Lai.
Yes.
Huang Lei.
Yes.
Meredith McKenzie.
Yes.
Thomas Stewart.
Yes.
Bruce Witcher.
No.
I'm sorry, you voted no?
No.
I had to move my pen. Deborah Wu.
Yes.
Ann Contreras.
Yes.
Emma Ramos.
Yes.
Pamela Davis Washington. Tamara McNeely.
Absolutely, yes.
Okay, that is 17 ayes, 1.
No.
It's not on here.
Who's not getting it?
I apologize. It's actually not on. We've missed him last time, too.
I know, because I come right after you.
Well, I think we're allowed to let someone add a vote.
The president would have to recall that item.
It's up.
Since there's another item on the,
Let's do this one first. You can vote now.
yes.
Yeah, you can vote on this
Oh,
one.
on this one?
Yeah.
And then we'd have to go back to the other one.
Or we don't. Or we
Or
don't.
you don't. But
It doesn't matter whether he would like to.
I think it would be best to go back after this because he's a board member, he's in attendance, and he was never asked for his vote. That's gonna,
Welcome.
that's gonna be real quick. Because everyone else has voted, if it's
I think
recalled,
he's
and then he
entitled to
votes,
vote.
and then we're done.
Which item are we recalling?
Which
Item
item?
Going back to 7.
Well, the minutes he would have
No,
abstained.
it's
That's
just,
right. Which one?
Mr. President, I move we reconsider item number 6 so
it's just the joint.
Board Member Chan can record his vote.
Approved. Reconsidering item number 6.
And that's actually the only one because he would not have been able to vote on the minutes.
What was the motion again? Can you repeat the motion for him?
Okay, the motion is to staff to work with OPES to.
No, it was just, the vote, I'm sorry. The motion was to combine the law and ethics and written exam.
Right.
That was it.
Gotcha.
Okay, moving on to agenda item 9, update the review of the registered dental assistant practical exam.
At the May 2016 board meeting, the board had requested that staff engage the Office of Professional Examination Services to review the RDA practical examination and determine what modifications may need to be taken. Since that time, we've met with OPES and we have engaged in an interagency contract with OPES to review our RDA practical examination. At the November UCSF examination, there was a member of the OPES team that came and observed both the administration of the examination and the calibration of the examination and the grading of the examination during different sessions. And so they are compiling their report. As part of this report, they will be holding a stakeholder meeting. We may be having a 1 or 2 day stakeholder meeting, and as well as different item workshops to discuss the examination. And so we will be working with the community to recruit subject matter experts to attend those workshops, and those workshops are expected to begin in January. So that was that item. I'd be happy to answer any questions, but we're rolling along, and I believe the timeline indicates that we're hoping to have a report, at least a draft report, by July 1st of 2017.
Tamara?
I would like to request that the DAC members be able to attend the examination as well, to be educated as to what OPS is doing, along with Dr. Wu, so that way when they attend the stakeholder meetings, they're educated and be able to participate equally.
That can't be done. Not a quorum of the DAC. Because it would have to be noticed.
member?
It would have to be noticed, and the public would have to be allowed to be there and observe as well.
Would a member of the DAC be able to attend?
Yeah, less than a quorum, absolutely.
Then I would like to request that a member of the DAC
Sure.
be part of that, along with Dr. Wu.
How do we decide who goes?
It should not be an educator.
Well, you just rolled me out.
Pam, you're up.
Yes, sure.
I think that everybody else,
Educators.
yeah, they're,
rest of us are
they have
educators.
something to do with education.
Pam
All of
would
them
be the
do.
only one.
Yeah, okay. So thank you, Pam, for attending.
Any other discussion?
Wasn't my intent.
Any other
but-
discussion from the board member or council?
Now, would we be able to attend the workshops? When the workshops are
I'd have to discuss that with OPS. I'm sure
No.
attending the stakeholder meeting, I'm not sure. I'd have to talk to, yes?
Yeah, if
Stakeholder
if
meeting?
it's a stakeholder meeting, absolutely.
So,
So we could attend.
Yeah. But again, if it's a quorum of members, it'll have to be noticed, the public will have to be there. But of course,
So
the stakeholders are going to be there anyway, but it would have to
So
be noticed.
maybe the chair or the vice chair can attend?
Sure.
Okay.
That'd be fine.
Any further discussion from the council or board members?
So,
Oh.
so my thought is if they go to the stakeholders meeting, they can't comment, right? Because it's going to come to them later, or come to us later, as maybe a motion, right? So they can go, but they cannot comment.
They should not comment.
No,
They should observe.
don't say anything.
Yes.
Correct, yeah.
That's right.
Public comment on agenda item 9? Seeing none, moving on to agenda item 10. Update regarding the registered dental assistant candidate guide.
this is just a quick update, because we didn't have it as a separate agenda item at the August meeting, but I wanted to make sure that the board and the Dental Assistant Council had access to the link that's been posted on our board website. So as a result of the May 2016 meeting where we discussed the occupational analysis, a request was made that staff work with the Office of Professional Examination Services to develop a candidate guidebook based on the materials that we had available for the RDA practical exam, including the grading rubric. And so as a result of working with OPS and their determination of what could and could not be released, the 2016 candidate handbook was released on August 15th, 2016, and it was distributed to all of the educators groups and the associations. It was posted on our board website, and we actually now print copies and include that in the scheduling notices with the candidates. Now, as a result of distributing the candidate handbook, we have been receiving some feedback, and I am in the process of working with OPES. There may be some tweaks that we're able to make for 2017, so there could be a revised copy coming out in January. But there's, again, there may be things that we can't tweak, that some of the feedback has gone. So if you have any suggestions or have heard anybody that wants to provide feedback, please have them email me directly, and I'll be happy to work with OPES to see what we can and cannot do.
Any questions or Tamara?
Would, we've been working, my staff and I have been working with the candidate guide and the rubric provided, and there is some confusion regarding that rubric. Rubrics are supposed to provide an objective guideline for grading, and it feels very subjective and still open to interpretation. And so I was wondering if there's going to be some clarity and changes to that grading rubric to provide more detailed guidelines as to the expectations of how the exam is being graded, or because we started using it, just to let you guys know, my faculty reported back that they're accepting things that they normally would not have accepted if they strictly go by the rubric. They're passing skills, competencies that they normally would not have passed. And so there's some definite issues with the grading rubric, and I just need clarification. Is that something that we can modify?
As I would expect that the grading rubric probably won't be changed until the report relating to the RDA practical exam comes out, and we have the psychometrician actually look at it and correlate it with the practical exam in her study. So that would be most likely rectified as a result of the separate study, and not something that we'd be able to do in a quick modification fix. We're looking more at clarity in the instructions for candidates so that they're clear on what equipment they might need to bring, or what procedures they're going to be tested on.
Any other questions or discussion? Public comment?
Melody Randolph. I just wanted to thank you all for creating that candidate guide. It came up as a result of some suggestions that the Daggers group made and other dental assisting educators, and we really appreciate your effort in bringing that out to help give the candidates more information about the exam. And just to let you know, I specifically had one student come to me and word for word told me some of the criteria on the grade sheet. So they are looking at it, they are considering it, and it is helpful. So thank you.
Thank you.
Ariane Trelay. So and I'm not sure if this is the place where the RDA law and ethics failure rate is huge. And this is something, I teach this to the dental students, and I hate to say this, but I generally tell them if they don't pass the law and ethics, they shouldn't be practicing in California. So there's something going on here with respect to the questions, or how it's worded, or people understanding the difference between laws and written laws and code of ethics, and I'm also concerned that a lot of these people, I know, who are a lot of my staff.
Excuse me.
Yeah.
No, you're fine.
You're okay, we're just.
But an item is going to have to be recalled, which is the examination
Which is this?
statistics. So that's item 4 is going to be recalled.
Yeah, we could do that if you want to. If you want to discuss it, we just have to
Recall
notify
that
everybody that because we were on the practical exam, you were talking about law and ethics.
So I can either leave or?
No, you can
It's
go
up to
ahead.
you, because.
You could go ahead.
Okay, so let me just finish. I think that one of the issues is that, the majority of my staff are bilingual because being in a community health center along with my private practice. So I really have concerns that the questions that are being asked, are they appropriate to people who are multilingual, and that there are not, and I haven't seen the questions, so I can't say. So I'm just going to give you an example of a question that came up on an exam talking about burnout. Okay, so when you're talking about burnout with, no, but this is not an exam. I'm giving you an example of a question on a board exam that has nothing to do with this exam. I'm just giving you, so let me finish, because it's not a question on the exam. So it had to do, was asking about burnout. So with people who the English is not their first language, it was specifically had to do with an x-ray. And talking about burnout it's a photographic term. Well, they were thinking that it's burned out as somebody that's burned out. So it was tired, and so I think that I just have concerns. This pass rate should be much higher. So I question the questions.
Okay, thank you. Okay, so back to agenda item 10. Any further questions or discussions, agenda item 10 for the board or council? Public comment? Moving on to agenda item 11, update of dental assistant council regulatory workshop.
We've been holding regulatory workshops for the public over the last year, approximately every 6 to 8 weeks. Our last regulatory workshop of 2016 is scheduled for Friday the 16th. And I would anticipate at this last scheduled workshop, that we will be wrapping up a couple of the sections, but that we will have a couple of more regulatory workshops in the beginning of 2017 to finalize all of the language and work out some more details. So it's not over yet, but we're hopeful that we're going to have a regulatory package draft in its entirety to come before the Dental Assisting Council and the board during 2017 at some point. So we're making progress.
Any questions or discussion from board members or council members?
It's just the regulatory workshops have been very helpful with getting all of the information out, what everyone is dealing with, and it's just been a really good collaborative effort. And so I just want to thank everybody and the stakeholders.
It has, and I think board staff's done an amazing job at working through those workshops. They're long and tiresome and tedious, but they've done a great job, so thank you. Okay, any further, Emma, no?
No.
Oh, I thought you
I'm
were.
good.
Okay. Any further discussions, questions on agenda item 11? Public comment? Moving on to agenda item 12, discussion and possible action regarding review of the draft regulatory language relating to the implementation of the additional duties of RDA-EF as specified in the Business Professions Code, section 1753.55.
So in 2014, Assembly Bill 1174 was signed by Governor Brown and essentially added duties to RDA-EFs to be able to make the determination of radiographs and do the ITRs. I'm sure a lot of you will recall a lot of the discussions, and it involves the Dental Hygiene Committee as well in relation to their license holders. And so over the last couple of years, we actually haven't had a whole lot of RDA-EFs that have been interested in the permit, and now we are starting to get programs that are interested and a couple of applicants for the RDA-EF permit. And so staff has drafted preliminary language just to get the ball rolling and get the ideas out on paper. And so we still need to meet with the Dental Hygiene Committee and their subcommittee to vet out the details, but I wanted to take this opportunity to get it out into the public and invite any board member or council member or even stakeholder that might have some valuable feedback to give us in relation to the draft language to email me. I don't know that we need to discuss it today because it will be brought forward to the board in the future in the Dental Assisting Council, and it would go through the regulatory process. But I would like to ask for any feedback or comments be sent to me, preferably by the end of December, so that we can move forward with the future development of this rulemaking.
Any comments or feedback from the board or council? Tamara?
This is just an administrative comment. I love how clean the application is, and it's easy to read and how everything is referenced, so kudos to you guys on that, because not all of the applications are as clear. So just kudos, just a little administrative kudos.
Just to reiterate what Sarah said, so this is your homework that can be done in the next couple of weeks, and we hope that you'll be able to provide her with some information. So if you're going to be leaving your binders behind, perhaps take this item out, take it with you, take a look at it when you've got some time, and then hopefully by the end of the month, you'll provide her with information. We'll bring it back again at a future meeting. That's the plan?
Yes, and keep in mind that this would be applicable to those that would already be licensed as an RDA-EF or licensed to perform the duties of an RDA-EF as of January 1st, 2010.
It's a permit.
It's considered a permit for the board purposes.
Where did the language come from? Or has this been looked at by Dr. Glassman? Paul?
It's just staff's attempt at getting something on paper. So it's a combination of Dr. Glassman's Health Workforce Pilot Project, number 172. So all of the criteria that was outlined in that curriculum, in addition to what we would need in our own regulations.
I was one of the people spending a couple years on that project and one of the evaluators, and so I just wanted I just would recommend that if you would want him to review this language to get his input, I think that might be helpful. But I'll look at it as well.
So we need a motion?
No.
We don't? Okay. Any further discussion or comments from the board members or council? Public comment?
Yeah. I'm Mason Amakian, Director of Continuing Dental Education at UOP School of Dentistry. I was actually working with Dr. Glassman on the application for the Health Workforce Pilot Project and saw it through the evaluation and the approval. So if you need any help on it, I'm more than happy to help.
Thank you. Okay, we'll move on to agenda item 13. Discussion and possible action regarding items requested by Ms. Joan Greenfield.
Oh,
Were
well,
there-
I was going up to say something to the last.
Oh, I'm sorry. I thought you were coming up because you knew you were coming up.
Yeah. Just a comment in regard to the last item.
We can go back.
We hope that moves forward as quickly as possible. I was one of the people who have an EF program that wasn't particularly interested in this until I realized how important it was to primary care and public health clinics. So we hope that we can move those regs along. Okay, so now.
Agenda
the other
item 13.
Thank you. Gosh, I'm waiting for the disco ball to drop from the ceiling. It's getting so late here for you guys. All right. Did you? Oh, sorry. I had submitted some information for your packet at the time I requested these items, but I guess the decision was made that some of that stuff would be handed out this evening instead. There are 5 items that I've asked to discuss, and the first 3 I hope that we can hopefully make some movement on this evening, if possible, because we have brought these up before in the past, and they do directly relate to the changes in regulatory hearings that you've been having, so it would be nice to have these things go along with that packet, if possible. I'll wait until all of these are handed out. Well, just for color reference.
None.
All right, thanks. The first item is kind of a lavender color, and that's just information that from a survey that we did, the EF Association did. You may recall that in late summer of 2015, I did appear before this board and brought these same things up about cord retraction and would you want to test composite posterior restorations on the EF exam instead of amalgam. We got into a rather heated discussion about amalgam. So rather than going to that place, we actually did a survey to show that in fact very few EFs are performing amalgam restorations. But rather than going and getting to another agreement or disagreement about materials, we've made a couple of proposals. The first thing that we talked about before was that we do have a lot of dentists who are concerned about the fact that we are requiring our students to do cord retraction instead of using some other method for dealing with tissue for prosthetics. And we talked about that at the time. You said you wanted to wait until you saw your analysis from your occupational analysis, but I don't believe there was any information in that analysis that would really help you make this decision. So what the EF Association is asking you to do, instead of using the cord retraction function that pre-exists now, is to change that to tissue, you'll see under item 1, tissue management for prosthodontic procedures. That gives both the providers of the education and the students and the dentists the option to learn a variety of different ways to deal with tissue management before doing impressions for prosthodontics. So that's the first item. I don't know if anyone has any question about that.
If we do, we'll ask.
Pardon me?
If we do, we'll ask.
Okay, yeah. Okay.
I have a quick question about how many, on this survey, how many answered your survey? Just for
21%. We had a 21.
How many did you survey?
Well, at the time, we believed there were around 650 people. I think we had 273 people answer the survey.
Okay, thank you.
Uh-huh. Okay. Item 2, if you opt to change cord retraction to tissue management for prosthodontics, that would mean, the way that the current exam goes is that the patient has a cord placed and is sent in to the examiners to be examined to see if the cord is in the appropriate place, if there's any tissue damage visible. The patient then goes back to the provider. They remove the cord and take an impression, and then that impression and the patient goes back in to be graded. If cord retraction is removed and tissue management is replaced with that, then there would be not a cord portion of the exam to grade, but there would be a portion of tissue damage that could be looked at the time the patient was checked for the impression. So that's part two. And the third part is that we talked about before. And rather than, say, getting into an argument over amalgam versus composite, even though our survey showed that very few people are placing alloys as EFs, we suggest that the term the restorative exam shall consist of both an anterior and posterior restoration utilizing restorative materials specified by the board. That gives you regulatory language that would not need to be changed in the future if you changed your mind as to what you wanted to test. There may be materials that come in the future that don't exist now, and you wouldn't have to change anything. And it does give you then the leeway as a board and or your examination committee to decide whether at some point you want, 1 year you want to test, or one exam cycle you want to test alloy, and another time you want to test composite or glass ionomer.
I have a question, Joan. Can we go back a little bit to the placement of the gingival retraction cord?
Sure.
And then the verbiage that's changing it to tissue management. So you say that the programs could teach a variety of different techniques. Can you elaborate on the exact techniques?
Right. Something we've just started adding to that, only telling them that according to law, it's cord retraction, but there are other there are a number of companies that are coming out and have come out with retraction pastes, for example, compression caps, other things that can be used either in conjunction with cord or not. We just 2 weeks ago were teaching this and had someone who was not successful in getting a good impression with cord, and we had them use the new 3M compression paste or retraction paste, and they got a great impression. It also allows us, some of these techniques, for those of you who are not dentists, some of these techniques are less invasive than the cord placement as well.
Yes, I have a question. So how will this affect the RDAEF who was licensed prior to 2010 that have not become EF2? At this point in
No,
time,
this has nothing, it would, the same thing, that is their duty.
Right.
The cord retraction and final impressions are their duty. That would allow them to use other methods.
Do they have to go back and take a course
No,
on this?
No, because actually, these other techniques are much less invasive than placing cord.
All right.
So no, and so what we end up saying is that this gives the dentist also the option to utilize the technique that they would prefer, because we're getting a lot of feedback from the dentist, the supervising dentists of our students who say, we don't want to do this cord. That's not what we do in our office anymore. And we say, well, that's what the duty is now, so.
Dr. Witcher?
Yeah, just a point of order. Our DAC members are running out of time. This is just an item that requests the board and council consider the requested items and prioritize and agendize for future discussion. And so I think this could be put off without really negating anything that you're trying to say here.
Yeah, the only thing that I was hoping that we do is those three. I understand that the next two will be some significant conversations, but because these three also fit in, as you know, with the because you've been at the regulatory hearing where I've testified on various things to do with EF, that this would fit in with that would go along with that package. It would make it simpler and cleaner to do. These are actually relatively simple things that we're asking for that would help clarify not only the education, but the testing situation.
So just to clarify where we are, Joan, so the 3 bullets, the first 3 bullets, you're suggesting should be incorporated into the regulations that are currently essentially being considered?
Yes, but I thought that these would probably require board approval rather than just, we have mentioned several things during the regulatory workshops that have been changed or language tweaked or brought up to current standards. But I felt that since I had brought these up in 2015 before, that these 3 items probably may or may not need your approval to do that.
At this point, I would recommend that there's a couple of things that can be done. So the first 3 items all seem to be related, and it would tie back to the examination. So if you choose today, you can choose to agendize these for a future meeting, either a joint meeting with the DAC and the examination committee, which is what I would recommend at this point, instead of the DAC and the entire board. And then take the other 2, which are scope of practice issues, decide where that would prioritize in a future meeting, just to move it along.
Could I make that motion?
Yeah, and can I second that?
Do we even need a motion? I think we can just request to have that on the agenda for a future meeting.
Okay,
Mhm.
good.
I think we'll make that request.
Does that require a roll call? No.
So to summarize what was just said, we will work to schedule an exam and dental assisting council meeting to be able to look at these 3 items, to discuss it, and then at least we'll have the background information to move forward to determine whether it can be folded into the regulatory package that's currently being worked on, or whether it's a separate item or whatever. Does everybody agree?
Yep.
Okay.
Good.
And what happens to the last 2? Well, that's a good question. What happens to the last 2, scope of practice? Is there any comment among DAC members or board members about how would you want to prioritize that discussion? Or Joan, if you had to choose, are they dealing with the first 3 or the last 2? Do you have a preference?
Well, I think
If they can't all be taken at the same time.
Right, I think they're 2 very different things.
Okay.
One is just taking existing situations and tweaking them to make them more useful for education and for the examination process. The other 2 are brand new. Well, I've brought them up before, but,
Right.
we have some significant information and have worked actually on a regulatory package.
Okay, so
here as
I would recommend that the timing of this is that these first 3 bullets fit into what already is being done, and it would be probably more timely to focus on those. The last 2, particularly because we're talking about levels of sedation, that would be taken up at a separate item as the board continues the discussion about sedation, just the big general picture of sedation.
All right.
Okay.
Okay. May I make a couple of comments about this before I know that you need to catch planes and so forth? I hope in the packet that you will look, that we presented for you today, there is a page, a couple pages back, that has a blue label on the top on one side and a purple label on the top and the other, and it says local anesthesia comparison charts. I did want to just say, and I'm not waving my own flag or anything, I just wanted to make you understand the reference point from which this comes. I taught dental assisting and dental hygiene for 37 years at Sacramento City College and through J Productions Dental Seminars. We're the first providers, private providers and the Sacramento City College to be allowed to teach hygiene, local anesthesia, and nitrous oxide. So we have 40 years of experience teaching these 2 particular functions. So that this doesn't come out of lack of knowledge. We have also been instrumental in helping COMDA when it was under COMDA and the board to look at some changes, and since then have been provided information to DHCC and letters to DHCC to tweak their regulations as well. So I want to make sure that we understand that this knowledge has a good basis and background for what we're doing. We've done a comparison between hygiene on a national basis, hygiene in California, and what we're proposing. So I'll take that into effect when you're looking at these items. And that we have taken the liberty to begin writing some regulatory language for both of these, so it would be a basis or some place to start from in the future.
Thank you.
Thank you, Joan.
Okay.
With no further questions or discussion from the board members or council, any other public comment? Moving on to agenda item 14, the Dental Assisting Council elections.
Okay, and only the Dental Assisting Council will be voting. Are there any nominations for chair?
I nominate Emma Ramos.
Emma, do you accept that
Yes.
nomination? Are there any additional nominations for chair? Hearing none? I'll say congratulations, but first we have to. Just for the.
Just for that.
Well, this would also include
None.
Witcher and Forsyth?
Yes.
Yes.
Yeah, they're on the
They're on the day.
Forsyth?
Yes.
Witcher? Contreras?
Yes.
Ramos?
Yes.
Davis Washington?
Yes.
McNeely?
Abstain?
Okay, that's 5 ayes, 1 abstention.
Congratulations.
Congratulations.
Thank you.
Nominations for vice chair? Are there any?
I nominate Ann Contreras.
And do you accept that nomination?
Yes.
Are there any additional nominations for vice chair? Hearing none? You can take the roll call, Steve.
Forsyth?
Yes.
Witcher? Yes. Contreras?
Yes.
Ramos?
Yes.
Davis Washington?
Yes.
McNeely?
Abstain?
5 ayes, 1 abstention.
Congratulations.
Yeah, that's the end of the, oh,
Just a,
Fran has something.
just a point of personal privilege. I wanted to extend congratulations to Ann Contreras, who has just completed her master's degree.
Wow. Congratulations.
Thank you so much. I wanted to continue my education because teaching is my passion, especially dental assisting. And I have the opportunity to do that with support from the council, the board, my family, and friends. Not only that, but I get to also work chairside on patients at the same time. So I get the best of both worlds. So thank you so much.
Great. With that, that concludes the joint meeting with the Dental Assisting Council and the Dental Board.
Thank you, Judy, for taking care of that, okay? We come to the point of exhaustion, yes, beyond exhaustion, recess. The board will be recessed until tomorrow morning at 8 a.m. We have some items that we were not able to accomplish on the agenda today. We'll pick those up tomorrow. We will start at 8 o'clock with a closed session. My expectations that it will probably be about 2 hours. So it looks like the open board meeting will probably begin at 10 o'clock in the morning, same place. And no, we will go ahead with the full board meeting as soon as we finish. I'm trying to give them some idea as to when it might be through. However, if you don't want to miss any of the full board meeting, you might want to stay close by. But I'm estimating that it will be 2 hours, okay? Now, also, apparently the restaurant in the hotel is closed. The only eating place is the lounge where we had lunch today. However, we have made arrangements to be served dinner at a restaurant that's walking distance outside of the hotel called Kincaid's. It's just a few minutes, apparently just up the sidewalk here. So if anybody is interested in joining in this group, we will be meeting in the lobby. Our reservation there is 7 o'clock. So I would say 15 to 20 minutes before 7, so which is maybe 20, 30 minutes from now. Meet in the lobby, and we will all go over together so that nobody gets lost and falls into the bay. Okay? So with that said, we will reconvene tomorrow morning at 8 a.m. for closed session. Okay.
Can we leave material in here?